So how do we use MRD in decision making? So first of all, we know from a lot of literature, mostly from the evaluation of patients with acute lymphoblastic leukemia or ALL, that MRD in blood cancers has a very strong correlation with prognosis. And this is, I'll give a few examples from the ALL literature and a little bit from the multiple myeloma literature, where we have a lot of growing literature about this. But we know that getting to an MRD negative state in most of these blood cancers has a very good prognostic significance. And so here is are two graphs from a very large meta-analysis of patients with ALL. And here you see for pediatric patients, so this was a huge number of patients, almost 3,000 patients. Those patients who got to an MRD negative state, so here in this top curve, their survival probability over time was much higher than those who never got to an MRD negative state. And this points to the fact that if you still have these tiny, minute amounts of disease that are left over even after a patient goes into remission, those cells can reemerge and result in a relapse and ultimately a poor prognosis for patients. And so this is seen very clearly here in this curve of patients who were from pediatric papers. And then here again, we see the same pattern in the survival of patients in the adult papers that were analyzed in this meta-analysis, where those who got to an MRD negative state where there was no disease detectable, even using the most sophisticated detection methods at that time, they did much better than those who did not get to that MRD negative state. Now, looking at ALL again as another case example, we see that using different MRD assessment methods really matters. So in the prior curves that I showed you, almost all of those studies used things like flow cytometry that I mentioned, or PCR, like I mentioned before, that have a good sensitivity, but they aren't the deepest, most sensitive tests that you can use for MRD and ALL. And in this paper from MD Anderson that was just published this year, they looked at whether using NGS, or next generation sequencing, that most sensitive MRD detection method, has the same prognostic significance as we saw using flow cytometry and those other methods. And so here you can see that patients who achieved an MRD negative state after one cycle of therapy, here in the blue line, they had a nearly 100% survival at this almost 4-year time point. So these patients did exceptionally well if using this very, very sensitive next generation sequencing testing after just one cycle of therapy, they had no detectable disease using our most sensitive testing. Contrary to that, we see these patients who were MRD positive using this very sensitive test after one cycle of therapy, and their survival was not nearly as good. And so this is a curve showing the significance of this very sensitive MRD testing tool after just one cycle of therapy. And then the researchers asked, well, what about after 3 months of therapy? And here you see at 3 months, we see the same pattern. Those who achieved any sort of MRD negative state by 3 months using this very sensitive test did very well compared to those who did not achieve MRD negativity by 3 months. And the same pattern exists with a 6-month time mark, where anybody who achieved MRD negativity by 6 months did better than those who at 6 months still had detectable disease. And so the reason I bring this up is to point to the fact that the method of MRD testing matters, and that at least in ALL, using these deeper, more sensitive MRD testing platforms like next generation sequencing still has a very similar prognostic impact as the prior methods that we had access to before next generation sequencing was invented and approved as a tool in ALL. And also that the timing of MRD negativity or MRD positivity really does matter, that those who achieved a very rapid MRD negativity did much better than those who took more time to achieve MRD negativity. One important thing to remember when looking at any of this data is that um, the significance of MRD really depends on what disease you're looking at. And so I wanted to bring this example from ALL to your attention because ALL is really one of the diseases where we started using MRD very early and where the prognostic impact is most clearly elucidated. But the same exact patterns might not exist if you're looking at myeloma or lymphoma or even acute myeloid leukemia. And this is just an example from the multiple myeloma literature, so another very large meta-analysis of MRD, and we can see that those who, in these darker colors, those who achieved MRD negativity had a much better progression-free survival. So the higher the curves are, the better it is. So these three curves in the darker colors, they all achieved MRD negativity, and it didn't matter whether it was a newly diagnosed patient who was transplant eligible, whether they were transplant ineligible, or whether they were relapsed. But if they achieved MRD negativity, they did much better than those who did not achieve MRD negativity, even in all of those different disease categories. So the achievement of MRD negativity really matters across different patient types with multiple myeloma. And because of all of the research into MRD in multiple myeloma and the strong correlation with this concept of progression-free survival, where patients survive without progression of their disease, MRD was actually approved by the FDA last year as a surrogate endpoint in clinical trials. And what that means is that MRD alone as an endpoint in a trial can lead to a drug approval. So the FDA has very strict criteria for the types of benefits a drug might have that could lead to approval. And now, because of all of this research for multiple myeloma, MRD alone can be a reason to approve a drug because we know that it is a surrogate, a kind of stand-in for these other meaningful benefits to patients like progression-free survival and overall survival.